Let me invite to start Don Crane, the CEO of America's Physicians Groups, to come up to the stage. Don, come on up. Appreciate you being here. So, you've been in the political and policy game for a long time. You've been able to work on a lot of different kinds of things, and I want to ask you about that full scope in a second. But first, a little more granularly, what is it that you're excited about in healthcare or health policy today, this week, this month? Like, what are the things that are commanding your attention right now?
So just a quick word, if I may, about APG. So we're national. We have 300 plus members now across, I think, 45 states and Puerto Rico. So along with our core California business, we now have got quite a perspective on what's going on like never before, office and staff in Washington, D.C. So anyway, we should know, should be smarter, hopefully, these days. So what are we excited about? The value movement continues apace. Perhaps not as successful or as fast as we'd like. I think we were all born around APG. We were born impatient. But it is indeed exciting, the new direct contracted models that are coming out. So members all across the country and other physician groups submitted their letters of intent by August 5. And now rumor is that within another week or two, we'll be hearing the long-awaited for sort of rules relating to two of these three directly contracted models, one being the sort of primary cap model and the other being the globally capitated model. And our interest level is extremely high because they're aimed right at us, basically, to a significant extent. This will be an exaggeration, but to sort of illustrate the point, we almost authored those things. So we had submitted white papers describing the models that we propose, very California-esque, a professional risk model, a globally capitated model, both directly contracted with CMS, and voila, last about April, I think it was, out they came. So they've been issued, but we've been waiting for further detail. I mean, how are they going to do the benchmarking? What are the rules around attribution? Sounds like, details, but they're all important. So we'll see. We'll learn more in the next couple weeks, and our big job is to sort of implement those across the country and help doing that. We're putting on webinars in cahoots with CMMI on how to do these models and stuff. So that's a big one.
Mm-hmm. And to be clear, these are direct payment models in the Medicare line of business.
It's Medicare, and it's original Medicare. So we're talking fee-for-service Medicare, going through an amazing transformation from that fee-for-service to value, and capitated or on the road to capitation at that. So that's a breathtaking, in my view, watershed dynamic that's occurring right now that will, I think, have profound implications across the country, and it will for California. And as they say, as goes Medicare, so go the other programs and products. And so I think it's got implications for all of what we're doing.
So you guys have become, in one person's opinion, certainly among, and maybe the most important physician voice, among the most important voices of Medicare Advantage in general, but certainly I would put you at the top of the physician voices in Medicare Advantage. I can't help but want to ask for clarity on that last point you made. As goes Medicare, so goes the rest of the country.
Yep.
Would this be a useful model for Medi-Cal?
Of course, because what we're talking about, is basically population health, prospective payment, defined population, defined benefit, and then physician group, primary care centric. All those attributes are within these direct contracted models. So they would remind us of what many of our members are doing in California and Medi-Cal now. They would look a lot like Oregon's CCOs, for example, very community-based, but all, global budget, big focus on total cost of care, sort of earn your living out of the savings associated with efficiency and eliminating waste. So all of that is what these models represent, and that will, I think, impact on Medicaid across the country.
Let me sort of offer a premise and see if it's valid or certainly editable. Is APG's commitment to empowering physician groups with these types of contracts, particularly direct contracts, particularly global capitated or some sort of risk-bearing contract, is that born from a frustration that California managed care has not moved quickly enough across any line of business, really, and so therefore the physician groups have been sort of forced to take more of a leadership role?
Well, we're frustrated with everything not moving fast enough and well enough, but it isn't really, we're not inspired by California as much as we're inspired basically by the Affordable Care Act, which gave birth basically to ACOs, then referred to as unicorns. There are now more than 1,000 of these unicorns running around. They're entrenched and embedded in the fabric of healthcare all across the country. But then along came, that was 2010, right? And then comes 2015 and gives us macro, which eliminates the SGR, but most importantly, created a kind of a no pay raise situation for physicians all across the country in original Medicare, right? But remember, that's the Medicare fee schedule, which is used as an index for the payments in commercial and elsewhere, so very important. And the way they project the administrative pay increases across the fee schedule, it's like, I think for 5 years now, we're in the middle of it, 0 pay raise, and then it moves into 0.25% and so forth. All of that is in my view, we're already into kind of wage and price controls. We worry about further sequesters and so on. I think MACRA gave that to us in effect, because when you say to the physicians of America, no more pay raise, at a time when their operating expenses continue to climb at 4, 5, 6% per annum, you're talking about a kind of a de facto pay cut, which over time is going to run them out of business unless they migrate into alternative payment models where they'll make their living basically on the savings, the delta between what used to be spent and what is now spent in a more efficient model. And so that is a watershed change, and that's all MACRA. And so, we cheered that, and we continue to try and implement it. So our national growth is because of the demand across the country. A lot of it's to sort of, look like California, if I can be so bold. But it's the genesis of it is the Affordable Care Act. And then the felt need from employers, payers, patients, physicians, to move from volume to value. We're all, I think, sick of an inefficient system and want one that presents more in the way of value.
Yeah. Likewise, the Medicare Advantage space has been a space with very modest premium raises over the last decade, essentially flat, and certainly below inflation. One of the things we've heard that I think is sometimes bantered around more as marketing or a throwaway comment than reality is that providers need to start learning how to live on a Medicare payment level of revenue based on or index to Medicare. Do you believe that there's enough money in, certainly everyone would like more money on the business side, but that there's enough money in Medicare with these alternate payment methodologies, with the tools built into a Medicare Advantage model? Is that a real statement that providers can and should learn to live on a Medicare reimbursement level?
So a categorical, emphatic yes when it comes to physicians and physician groups. So our experience, for example, in Medicare Advantage, where the cap rates and the premium are derived from the fee-for-service spend, right? So there's the county book rate, but basically it's all pinned and indexed to fee-for-service level, so Medicare, as it were, right? And so groups in Medicare Advantage are doing very well. It's a very successful program. And so they're effectively living within a Medicare rate. So there's my answer as regard physician groups. I'd turn to hospitals and let them speak to whether they can live within Medicare.
Yeah.
And I think you get a different answer, much tougher for them given the economics around hospitals. They're certainly on the provider side. So you get a kind of a split answer in terms of who you pose that question to.
Yeah. It's interesting to hear you say this. So this afternoon, I mentioned when we opened this morning, I told you, I think in the hallway, I'm going to give this presentation, 5 things we're watching in healthcare, California healthcare. One of the things is this rate setting,
Yeah.
rate caps that I think are
Yeah.
all over the place, and we're sort of have our head in the sand a little bit on it.
Yeah.
Given sort of how much that has been directly and indirectly applied in the Medicare space, do you think that the rate cap methodology, whether it's a benchmarking or a limit tied to some percentage of Medicare, do you think that that is a reasonable model that should be extended to other parts of the healthcare system because it has largely worked indirectly in other areas?
Well, I think we're going to see it. So once upon a time when Paul Ryan issued his, whatever it was entitled, Plan for American Healthcare, so a very Republican kind of proposal, whether we'll see something out of this administration or not, I don't know. They were going to do one. But so there you saw premium support, you saw block grants, and so you saw effectively what you're talking about, which is a kind of a ceiling and you get no more. Mm-hmm. So there's that kind of, I think, a political dynamic. But even outside of the political world, I don't know that anybody's getting paid more. Mm-hmm. It's all about making do with less. And I think that really is the catchword for providers all around the country. Mm-hmm. And of course, our answer to it is work differently. In other words, live within a capitated model where the incentives are all aligned to keep the patients healthy and reduce spend by reason of healthier population as opposed to a sick population. When done and done right, our experience has been there's been more than sufficient. Don't tell CMS this, but when it's done right, there's enough money to cover all of the providers pretty well. So this dynamic of kind of a cap and a possibly ratcheting downward kind of finite spend is what we're going to be seeing. We have no choice.
So, if I might be a cynic for just a moment, sometimes associations are used as a tool to slow walk policy changes, where an association member might not want their brand associated with an opposition campaign. We see that there's a lot of that going on in DC related to Medicare for All. Why is it that your association is really so much more of a innovator? Why are other associations, this is not specific to anyone, but sometimes associations are the last to come on board with any real movement. And I know it's because of your members and your board. So what is the secret sauce there?
Well, so good question. So it indeed is the case that an awful lot of associations operate sort of like guilds. And their principal purpose is to get their members paid more or faster or the equivalent, right? And so we're different because we don't say pay us more. We say give us the population. I mean, pretty much give us the volume, period. And then we add to it and we'll return it to you in a healthier condition. Because we know that given the benchmarking and so forth, that amount of spend is sufficient. My members will probably kick me for saying this, but indeed the amount of fee-for-service tied reimbursement is adequate, at least in Medicare. I'm kind of focusing mostly on Medicare right now as I speak. And when, the emphasis is on early intervention, prevention, stratifying the population, determining who needs help now, the 5% that's driving 50% of the cost. Maybe more importantly, the balance of that population that's going to be sick next. So think predictive modeling and maybe even artificial intelligence. Mm-hmm. When you start to identify who's going to be sick next, all of a sudden, there's plenty of opportunity to reduce healthcare spend and improve the health of the population. We see that. So knowing that, we don't say give us more at this point. We say give us the population. And so it spawns kind of a more innovative approach. I mean, most of other associations, their heels are in the sand a little bit because they want to preserve what they've got, which is doing moderately well for them. But we simply aren't like that. It's just the ethos of APG to be more innovative.
What would you say, what have you learned about the sort of changing nature of the plan-provider relationships in the Medicaid space, Medi-Cal space in particular, and in particular in Los Angeles County, there's been significant change in the construct, the organizational relationships, What are your takeaways from that last 3, 4, 5 years of work?
So I would start by saying generally that we live very happily in a capitated delegated model where we work in close cahoots with our plan partners, each doing that which it is best at, frankly. And so in that model, groups will pay claims and they'll do credentialing and they'll do the quality and utilization management and all of the quote-unquote delegated functions. And that works brilliantly well when it's fully deployed by capable groups. Mind you, emphasis on capable groups. And so that we see, growing rapidly across the country. So born in California, I think it can be said, but plenty of it outside of California now. So that's sort of generally what's going on in terms of plan-provider relationships. So just next week, for example, we jointly with AHIP are putting on a session to AHIP members on how to move into delegated models. This is a national movement, right? So move back into California and any other state, and then all of a sudden you get regional variability. And California, of course, has a rich history in plans and groups working closely and well together. But it's stressed and strained, any number of reasons for that, and evolving, I might add. LA County, John Bacchus will probably give you better answers than I will on it. There's no question that I think health plans are interested in excellence out of groups, frustrated by some groups that in their opinion don't do a good enough job. And on the other side of the table, the groups are sometimes frustrated at health plans that intermingle where they shouldn't, don't pay them enough, interfere, don't give them real-time feeds on data, make their life miserable. I mean, those are the sort of day in and day out kind of frustrations. But I mean, at a high level, I would again say that maybe health plans aren't going to deliver care. Physician groups really don't want to go into retail health plan. We're going to stay married in hopefully a harmonious marriage and continue to do better together. I think the vision is the same for both, basically. And we really do want to get to affordability. We want to get to higher levels of health, basically. So that's what we're working on.
Well, I know it is a nuanced role that you play leading physician groups, where as an AMA executive some years ago said, look, we got the best job because 90% of our members are in the top half of all caregivers, or top half of all physicians. So the Lake Wobegon effect is in good effect. Don Crane, CEO of America's Physician Group. Thank you very much, sir. Appreciate it.
My pleasure. Thanks, DJ. Okay.
Good stuff.
Thank you. Thanks for having me.